Thanks, Bernie, and thanks to all of you for being here today. I really enjoyed this morning's conversation. I'm looking forward to a full day of robust and practical suggestions and solutions. As Bernie mentioned earlier, and this comes out of work by the IOM and some task force reports by the AAMC later, we really are talking about two primary goals when we talk about COI policies: maintaining the integrity of research data, which often we talk about as explicit bias or actual bias. And there's been a lot of discussion this morning about the perceived bias in this second goal of preserving public trust. I think that too little focus is put on this second goal, and sometimes it's brushed off as also we have to keep the public trust. In my opinion, this is absolutely fundamental to our research enterprise and moving things forward. And in fact, as I'll discuss a little bit later, is essential in not just managing conflicts of interest, but also facilitating innovation. Now, it's important to keep in mind, Sally mentioned some of the pieces in the new regulations that have also were in place in the 1995 regulations from the Public Health Service. That there are several different elements of conflict of interest policies, and we're using this term very broadly to suggest, in some cases, institutional policies and how those, what requirements those put on investigators, or federal regulations, state regulations, and professional society standards. They have things in common, but we should be clear when we're making recommendations about what COI policies should or should not include, at what level we're talking about these policy decisions. The impact of different parts of these regulations or standards or policies may differ based on these elements. So, for example, the guidance or limits that certain institutions or certain professional societies or others put on specific activities or specific relationships may have a very different impact on the potential for innovation than the elements of disclosing to institutions, of reviewing conflicts of interest and managing them, and in more recent time, the public disclosure of certain relationships. Now, the ultimate question really is, are we getting the balance right? And I don't want us to think that the balance that we're weighing here is between conflict of interest policies and innovation. I don't think those should be set on different sides of a scale, but to have robust, effective policies and standards that both protect data, research subjects, patients, and accelerate innovation, accelerate discovery, and lead to the better health for all. Now, we're talking, want to be clear, most of what we're talking about today has to do with conflict of interest policies related specifically to biomedical research. That's not to say that there is not innovation that happens in the clinical care and education settings, and it's not to say that there aren't conflicts of interest or conflict of interest policies that have to do with professional judgment in clinical decision making. The focus of both my talk and much of what we're talking about today is on research, but it bears thinking through that as we move towards more of a learning healthcare system where the boundaries between research and clinical care are not always and shouldn't always be as black and white as we consider them in every way, that these issues run into both clinical decision making and the rest. So I've mentioned that the potential impacts on innovation can be positive, and that having a robust policy and a practice that engenders the trust of the public can help with subject recruitment, with faith in data that comes out, with a decrease in skepticism in the media and others about research results, in increased funding, in increased collaboration. But what we hear are some concerns, and many of them have been voiced today, about what the potential negative impacts of certain aspects or certain elements of conflict of interest policies or regulations may be on innovation. One that Sally brought up and we hear all the time is the differences between a financial interest and a conflict of interest, and then even more important, the difference between a conflict of interest and misconduct on the part of an investigator. And this is not an idle concern. In my role at the AAMC, I often talk to reporters on a regular basis, and I find that a very good opportunity to do some education. But the question that I get almost all the time is, we've discovered that Dr. So-and-so has a $10,000 conflict of interest with a certain company. Doesn't that violate their policy? And we have to step way back and think, well, actually a conflict of interest is not what we've discovered. We've discovered a financial interest, and it's not a discovery in a way that necessarily leads to a problem. I think that Guy Chisholm spoke very eloquently earlier about the importance, and others, of having policies and having the public and patients and subjects have faith that the policies that are the underlying mechanisms are robust. And so that when you see something like, here's a financial relationship, even if you don't see all the mechanisms under it, you know that there is a process for reviewing that, for vetting it, for thinking about what the potential bias is in moving forward. This very closely related concern is the perception that many investigators hear, and I hear it from investigators and institutions all the time, that all relationships with industry are tainted, and whether they should embark on this at all, given that they feel like they're having an uphill battle when they engage in collaborations with industry. One thing that I think has really underpinned a lot of what we've heard today, and I think that we will tomorrow, is not tomorrow, today, but this afternoon. You're going to be here for 2 days. You didn't know that, did you? That transparency is very important. It's absolutely critical in trust and the like. But transparency without context is very problematic and can lead to some concerns. We've heard a lot about multiple sources of conflicting data. Several speakers talked about this. I thought a quick example might just show you with some real numbers how this works out. This is actually a relatively simple relationship between an investigator and a pharmaceutical company. Dr. B got $2,500 in consulting fees in August of this year, so this is forward-looking. She flies from DC to Chicago for a scientific advisory board and gets paid $1,000 for serving on that advisory board in December, and another one in February. So Dr. B reports to her institution no significant financial interest. That's because she received in payments of $4,500 under the $5,000 limit that her institution has set, and there's no significant financial interest that needs to be reported. Even if it had been reported, had the institution not considered it a conflict of interest, then it would not be part of the public disclosure system. She discloses to a journal that she has a paid relationship with this company, because she does. She then gives a CME presentation and says she's made $4,500 in the past 12 months, because all 3 of those payments were in the past 12 months in May. But in September, she discloses in another conference that she's made $1,000 from that company in the last 12 months, because that's what she got in the last 12 months. Similarly, in September 2014, the Sunshine database comes out, and the company says they've made a transfer of value to Dr. B of $5,100. That's because they paid her $2,500 in August, $1,000 in December. The $1,000 in February, even though it's September, isn't part of the database yet, but also they paid for her plane ticket and her hotel, and they fed her 3 meals a day, and that is a transfer of value that was not in cash to her. These conversations are happening in not just here, but all over the place. There is a lack of trust and concern that we need to move forward. The National Dialogue on Healthcare Innovation, you'll hear from Mary Greeley of the Healthcare Leadership Council later today, came up with 4 statements of principle for collaboration. And at AAMC, through the Forum on Conflict of Interest in Academia, we've had several discussions about how we create safe havens and better advance the research missions through principled partnerships with industry, thinking about a lot of the models that Dr. Cohen raised earlier today. So this brings us to, I'm going to talk very briefly, and we can discuss more later, the AAMC CEOI Metrics project. Our last panel talked about the need for data, and we agree. And so what we decided to do is to collect data from academic institutions that can't be collected necessarily by the government or others, and say, what is the impact of this new rule that Sally was just telling you about? The goals are to come up with institution-specific benchmarking, but also to aggregate the data from the institutions and provide it to the NIH to say, could you use this information to do an orderly retrospective review of the rule and look at what the impact and the effect and the effectiveness is? We hope that this is a model for what is incredibly important to us and our constituents, which is evidence-based regulation, which was brought up in the last piece. Are there ways to do the research in advance and to provide some sort of piloting project or something so we don't end up in a situation like the duty hours and others before we implement regulations that have huge impacts? We were hoping to have 25 institutions sign up for this project because those institutions commit to 4 years of providing us with aggregate data of all of their financial interest information that they collect and all the financial conflict of interest information they have, as well as many other aspects of what they're spending to implement this rule. We have 76 institutions from across the country that signed up for this project and have already provided extensive background and historical data about what the information they were collecting before implementing the new rule. So they registered in the fall. In March, we began collecting this information on what they were doing before implementing the rule. And after August 2013, when the rule's been in place a year, institutions will start giving us information about what they're collecting each year. Some of the information that we're collecting, what did you do to prepare for the new rule? What was the cost of implementing this rule? Did you have capital investments, infrastructure changes? Did you hire new people? What's the impact on your faculty? And then as baseline data, what were you looking at before? How many financial conflicts of or financial interests did you collect? How many were determined to be significant financial conflicts of interest and reported to NIH or the other funding entity? And then each year, they're providing to us information about their ongoing administrative costs, whether they're hiring new people, changing their policies, changing their processes, and then how many financial interests they're looking at, how many financial conflicts of interest they're identifying, and very importantly, we're looking at the specific changes in the new rule, like lowering the threshold of disclosure to the institution from $10,000 to $5,000, and asking, are you finding and reporting financial conflicts of interest between $5,000 and $10,000? What is the volume there? Are you finding and reporting conflicts of interest related to travel, which now needs to be disclosed and reviewed by your institution? And we're hoping that by doing this that we can collect this information and really get a sense of what are institutions spending to implement this rule, and are we getting at the fundamental questions that the changes in the rule intended to do. So we're now just starting to analyze that background data, and we'll hope to have updates, interim updates as we go. There's more information at the amc.org/metrics project, and I'm happy to answer any questions during the panel. Thank you.
Thanks very much. I think we'll all look forward to the data and analysis from that metrics project. And to give the government perspective, We have Krishna Balakrishnan, who's from NCATS, the National Center for Advancing Translational Sciences, which is part of NIH.